The topic given to me was when and how to manage type 1 ROP and AP ROP. Okay, so this paper has been presented in World ROP Congress in 2017 in Mexico, and these are the learning objectives of this paper. The with the increase in the premature births, the ROP became a leading cause of childhood blindness, and the current gold standard, as suggested in the ET-ROP, was lasers, which does not rule out the poor outcomes in more virulent form of ROPs. So the laser therapy, we all know, causes some field loss. In 2007, there was, before beat ROP, the first 3 reports of the use of bevacizumab came into literature. Then this beat ROP came as publication, and there was a paradigm shift which showed that these babies who received injection started doing better in terms of anatomical success rate, and this form of treatment was much superior to the conventional laser therapy for zone 1 diseases, and but not for the zone 2 disease. And this was a bit of a setback, but of the 7, there were 7 deaths reported in this. The 5 were in the bevacizumab group, that is 71% of the mortality happened in the bevacizumab group, but this was not statistically significant. Then last year came the rainbow trial. Our institute, Madurai, was a participant in this, and which again showed that the 0.2 milligram of ranibizumab is superior to lasers and has a lesser unfavorable outcomes. Advantages were of injections are simplicity of injection, rapid action, decrease loss of visual field, and continued retinal growth. Why do we need follow-up? Because very late activation is known, like in this child who received and after 2.5 years developed tractional retinal detachment. So also we had published this data of neurodevelopmental disabilities in premature infants, and we were a bit apprehensive of the usage of this thing. The logic was that the reduction of the systemic VEGF will have implications in the development of the organs. So this paper was published in 2017, and this showed that this was a protocol which I had designed in Madurai, and we were following this protocol. And this is basically a publication on the retrospective study, and the primary outcomes of the inclusions were babies who had severe ROP and were treated with anti-VEGF, and the babies were treated with laser only when the anterior growth of the vasculature was arrested, and or there was no change in the 2 weeks. So the primary outcome was to avoid any recurrence, anatomical success at 1 year. The results were good. 14 babies had AP-ROP out of 3,792. 15 had zone 1 disease or zone 2 posterior. NVI was seen in 3 babies. This was the other data of the mean age of treatment, and the laser was done at 44 weeks. Mean duration of difference was 9 weeks to plus minus 7 weeks. Mean follow-up was up to 13 months to 15 months. None of the eyes we lost in terms of recurrence or unfavorable outcome. In our series, using a treatment protocol, devastating complications associated with blindness were avoided. Our proposed protocol of IVB monotherapy with deferred laser treatment can be used in severe ROP patients with poor conclusion. And the conclusion, I'd like to say that the patients with ROP had significant neurodevelopmental delay, which is related to degree of prematurity. So not at all we have to think in terms that it is only because of the anti-VEGF. Zonal involvement was also shown in our paper. Aggressive posterior ROP continues to possess management challenges, and anti-VEGFs are being considered for zone 1 diseases. The safety concerns are there, though we have to give these injections for type 1 diseases. It's not a one and done therapy. ROP can recur, lasers can be done later. the take-home message is that the golden standard is still the laser, but for the zone 1 disease and severe ROP, this can be tried. Anti-VEGF also change in the pathophysiology. Use of anti-VEGF should be for longer. We can consider laser as supplemental form of treatment when the patients are non-compliant. Thank you so much.
Thank you, Dr. Manish. That was a very nice presentation. Very well summed up.
Hello. May I ask the next speaker? That is Dr. Santosh Agrawal. Any questions for Dr. Manish? Can we have the lights, please?
The lights के लिए time लगता है.